Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentaries on a JCO article, a meta-analysis evaluating the impact of site of metastasis on overall survival in men with castration-resistant prostate cancer by Dr. Susan Halaby and colleagues. My name is Niraj Agarwal, and I'm an Associate Professor of Medicine and the Director of Genitourinary Medical Oncology at the University of Utah Huntsman Cancer Institute in Salt Lake City, Utah. My oncologic specialty is medical oncology with a focus on genitourinary oncology. In this meta-analysis, the study team investigated the influence of site of metastasis on overall survival in individual patient-level data from 8,820 chemotherapy-naive men with metastatic castration-refractory prostate cancer who received docetaxel chemotherapy in 9 phase 3 trials. Site of metastasis was categorized as lymph node only, bone plus minus lymph node with no visceral metastasis, any lung metastasis but no liver, and any liver metastasis. About 73% patients had bone plus minus lymph node metastasis, followed by approximately 21% patients with visceral disease, and only 6% men with lymph node only disease. Men with liver metastasis had the worst median overall survival of 13.5 months, although men with lung metastasis had a better median overall survival of 19.4 months compared to men with liver metastasis. They had significantly worse median survival duration than men with non-visceral bone metastasis, whose median overall survival was 21.3 months, or men with lymph node only disease, whose median overall survival was 31.6 months. The differences in overall survival in each of these groups were statistically significant. The authors concluded that specific site of metastatic disease in men with metastatic castration-refractory prostate cancer are associated with difference in overall survival, with successive increased lethality for lung and liver metastasis over bone and non-visceral involvement. In my view, this is an important study building on prior work identifying prognostic factors for metastatic castration-resistant prostate cancer. These data validate the clinical observation that the presence of visceral metastasis is a negative predictor of overall survival. Major strengths of the work include the use of patient-level data and careful statistical analysis. The information provided by this study have important implications on the design of the future clinical trials and will likely help to direct patient care and treatment decisions. Although 5 agents have been approved in the last 5 years for the treatment of men with metastatic castration-refractory prostate cancer, many more have failed to show a survival benefit in randomized phase 3 registration trials and in garnering approval. This was despite the fact that most of these agents showed promising results in earlier phases of trials. Is it because the drugs were truly ineffective, or was because of suboptimal patient selection? Indeed, as the authors mentioned in this paper, it is intriguing to note that variability in overall survival for each metastatic site subset across the trials was not large, suggesting that differences observed in overall survival from trial to trial could be explained by the relative proportion of the metastatic subsets enrolled in each particular trial. Thus, Immediate impact of these data may be in their use in clinical trial design, stratifying patients during randomization, or to select patients in metastatic castration refractory prostate cancer clinical trials. These findings have the potential to help with statistical power calculation, which is based on anticipated overall survival in a given cohort of patients. For example, trials focusing on men with liver or lung metastasis who have relatively shorter overall survival may need a smaller number of patients for showing significant treatment effect compared to clinical trials targeting men with lymph node or bone-only metastasis with much longer anticipated overall survival, and which will need a higher number of patients to show a similar treatment effect. Another important aspect is patient selection based on site of metastatic disease. Clinical trials utilizing therapeutic agents associated with a delayed treatment effect, such as immunotherapeutic agents, may benefit from including men with bone and/or lymph node-only disease, where the anticipated survival is longer, thus providing adequate time to these agents to exert their effects. In contrast, clinical trials utilizing therapeutic agents providing immediate cytoreduction should include patients with liver or lung metastasis, given the anticipated rapid disease progression and a much shorter survival. These data also have implications for the site-specific tissue sampling for biomarker-based trials prior to patient enrollment. Based on these results, it is likely that biology of liver or lung metastasis drives survival outcomes. Therefore, biopsies from liver or lung metastasis may yield more relevant information about the underlying molecular biology of disease progression compared to biopsies from other, more accessible sites, and subsequently aid in more appropriate patient selection for these clinical trials. These data also have implications for patient care. First, these results enable patients to be counseled about their disease prognosis based upon their unique and individual site or sites of metastasis. Second, similar to their implications on patient selection for clinical trials, these data will likely be helpful in selecting patients most appropriate for the currently available therapies, including immunotherapy, androgen signaling inhibitors, chemotherapy, and clinical trials, and furthermore, in assisting clinicians in the sequencing of these agents based on the anticipated survival of their patients. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.